The following podcast is part of a certified educational activity titled Improving Kidney Transplant Access and Equity with Innovative Immunosuppression Strategies. Access the entire activity and complete the post-test at peerview.com/SVZ860. Downloadable slides and practice aids are also available.
Hello, everyone. I'm Dr. William Kitchens, an associate professor of surgery at Emory University Medical School and the program director of our abdominal transplant surgery fellowship. And I'm here to talk today about improving kidney transplant access and equity with innovative immunosuppression strategies. Our goals for today are to augment your knowledge of available maintenance immunosuppression regimens for renal transplant recipients and also provide guidance on ways to overcome inequities in renal transplant care and address the role of optimal immunosuppression in addressing these disparities, and also equip you with strategies for implementing personalized maintenance immunosuppressive regimens in your renal transplant patients. We're going to start by just discussing one of the key struggles in the field of renal transplant today, and that's the fact that while short-term outcomes have certainly improved over recent decades, the long-term outcomes really have not improved dramatically over recent decades. While there is indeed a decreased rate of acute rejection due to a variety of factors, including better cross-matching and improved surveillance, you can see from the slope of these curves of deceased graft survival that the slopes are almost identical. So whereas short-term outcomes have improved, the long-term outcomes that we care about so much for our patients really have not improved from the 90s to the 2020s. And there's some recent advents in immunosuppression that might offer some hope to move the needle and improve the long-term outcomes for our patients, as about 10% of renal transplants these days are for actually retransplants, highlighting the issue of graft loss in our renal transplant patients and our desires to use improved renal transplant immunosuppression to have one kidney transplant for life for our patients. To take a step back to the pathophysiology of kidney transplant rejection, we know that antigen-presenting cells such as B cells, macrophages, and dendritic cells and T cells coordinate to create a toxic inflammatory environment that targets non-self tissue such as the kidney allograft. And it's thought that T cell activation of at least naive T cells is dependent on three distinct signals that are targeted by modern immunosuppression medicines. So signal one is transmitted via the T cell receptor, and this is disrupted by calcineurin inhibitors such as cyclosporin and tacrolimus, which block the calcineurin-mediated activation of INFAT by TCR ligation. Signal 2 is transmitted through a variety of different costimulatory receptors, such as CD28 B7 interaction and CD40 ligand interaction. And this can be disrupted by drugs such as belatacept, which is the only FDA-approved costimulatory blockade agent for use in kidney transplantation. Signal 3 is transmitted via a variety of cytokine signals, and this helps promote the shape of T cell responses. And many of these cytokine signals ultimately activate the mTOR pathway and then the cell cycle pathway. And this is blocked by mTOR inhibitors such as rapamycin or everolimus, as well as a variety of antimetabolite agents such as MMF and azathioprine. Now, despite the advances in clinical immunosuppression over the last few decades, transplant rejection remains a very fundamental problem facing many of our kidney transplant recipients. And depending on the series, somewhere between 7 and 20% of kidney transplant recipients will experience one rejection episode within the first year post-transplant. These are usually manifested, as we know, by increases in serum creatinine and BUN. And it can be confirmed either via biopsy or, more recently, donor-derived cell-free DNA. Now, when we talk about immunosuppression for renal transplant recipients, this is often divided into induction immunosuppression, which is things like steroids, thymoglobulin, basiliximab, which are administered at the time of kidney transplantation, so usually in the operating room. And this is distinct from maintenance immunosuppression, which is the continuous immunosuppression that the patients receive after the induction phase to maintain long-term allograft function and prevent rejection. We're going to focus on this talk on a maintenance immunosuppression rather than induction immunosuppression. And there's a few different classes of agents that serve as these maintenance immunosuppressants. Firstly, the calcineurin inhibitors, which are drugs such as cyclosporin and tacrolimus. Tacrolimus definitely becoming the dominant CNI utilized in renal transplantation for at least the last 20 years. Then there's the antiproliferative agents such as mycophenolate mofetil or MMF and azathioprine, which is an older drug, less commonly utilized these days. There's the mTOR inhibitors such as sirolimus or rapamycin and everolimus. And then there's the corticosteroids, which have been a mainstay of immunosuppression really from the advent of clinical transplantation. And finally, the new kid on the block are the costimulatory blockers, of which currently the only FDA-approved one is belatacept. All these drugs have important utility in renal transplant recipients, and they also have very distinct adverse reactions and side effects. And it's the balance of these side effects versus benefit that largely guides the individualized immunosuppression plan utilized for renal transplant patients. Definitely the most commonly used regimen in de novo kidney transplantation throughout centers in the United States and Europe is a combination of a CNI, which is usually tacrolimus, mycophenolic acid derivative, such as MMF, and then plus minus a corticosteroid. And the Symphony trial was a seminal clinical study that really demonstrated that tacrolimus maintenance immunosuppression was superior to either cyclosporin or sirolimus in kidney transplant recipients, which is why tacrolimus has really taken on a dominant role for maintenance immunosuppression in kidney transplant recipients. Additionally, tacrolimus has a more favorable side effect profile than many of the mTOR inhibitors, such as sirolimus, which are plagued with issues such as proteinuria, as well as wound healing issues that we don't commonly see with the CNIs, such as tacrolimus. This regimen definitely is very, very effective, and is the reason why nationwide the 1-year graft survival for a kidney transplant is somewhere in the 95 to 97% range, which is a dramatic improvement from the 1-year survival back in the early 80s in the pre-CNI era. But this regimen does have some downsides, and certainly the nephrotoxicity that is inherent in the use of CNIs is thought to be a common reason why allografts do suffer chronic allograft failure. And and looking beyond this regimen may, as we'll talk about in a minute, may be a way to achieve better long-term allograft outcomes. I'm going to talk briefly about some important new developments in this traditional regimen. One is the recent emergence of once-daily tacrolimus formulations, of which the most common are Invarsys XR and Astrograph XL. These are both extended-release tablets that, rather than the twice-daily formulation of traditional tacrolimus, allow once-daily use. And this has an important benefit. It has a more consistent pharmacokinetics and allows more steady trough concentrations, which is thought to lower the risk of renal toxicity. It also offers a simplified dosing schedule to our patients, which may improve patient adherence and certainly convenience for renal transplant patients. And there have been some enticing early studies that showed that once daily tacrolimus may have some improved clinical outcomes versus twice daily formulations, mainly due to this improved adherence and more predictable trough concentrations. It's important to note as well that the Invarsys and Astrograph are definitely not interchangeable in terms of dosage. So there's definitely some important titration between the twice daily formulations and as well as these once daily formulations. There's also multiple different formulations of mycophenolic mofetil. Definitely the most common are CellCept and Myfortic. One benefit of Myfortic is that it's enterically coated for delayed release, and it may offer some benefits in terms of less GI side effects, which is a common phenomenon that we see with CellCept use. And so Myfortic, because it is enterically coated, may be a good option for patients that have profound nausea or diarrhea that's thought to be due to the MMF use. The issue of whether steroids should be part of a maintenance immunosuppression regimen for kidney transplant patients is definitely one with a lot of controversy. According to more recent case series, probably around 20 to 30% of patients in the United States are on early steroid withdrawal or steroid-sparing immunosuppression regimen. But there's definitely a lot of controversy about whether steroid-sparing maintenance immunosuppression truly is worth the benefits. The putative benefits of avoiding steroids is that it avoids a lot of the problems that we see with chronic steroid use, such as a variety of metabolic side effects, increased risk of hypertension, diabetes, and Cushing's syndrome, and other neuropsychiatric side effects. But there have been multiple studies looking at early steroid withdrawal with somewhat not encouraging results. So one of the seminal studies was done by Woodall and colleagues and published back in 2008. This was a 60-month-long randomized controlled double-blind multi-center trial of steroid-sparing immunosuppression. And this looked at early steroid withdrawal within 7 days versus chronic low-dose steroid therapy. And what this found was, in contrast to their expectations, there was no real difference in the groups between the cardiovascular risk, the weight gain, the new onset diabetes after transplantation, and the kidney function. But there was an increased risk of acute rejection and chronic graft dysfunction with the early steroid withdrawal arms. So you can see here in this chart that the rates of biopsy-proven acute rejection was higher with corticosteroid withdrawal than for patients that were maintained in low-dose steroid therapy. There was a subsequent Cochrane review in 2016 that looked at 48 different studies looking at early steroid sparing or early steroid withdrawal immunosuppression versus continued steroid use. And it found that steroid avoidance after kidney transplantation was significantly associated with increased risk of acute rejection compared to regimens that maintained steroid use. So the data in support of early steroid withdrawal is definitely somewhat controversial, and that's why likely the majority of centers in the United States and Europe still have prednisone as an important pillar of the maintenance immunosuppression regimen. Now, although the advents in immunosuppression and clinical management of transplant patients have definitely improved dramatically over the recent decades, there are groups that have really not benefited as much from the clinical developments in kidney transplantation. And that includes groups such as the elderly with minimal wait time, who often die on the wait list before they can get a kidney transplant. African Americans who often face longer wait times for a kidney transplant due to a multitude of factors, and then highly sensitized patients as well who have difficulty having access to kidney transplantation. So all these patients definitely face often longer wait times and higher waitlist mortality waiting for a kidney transplant. And that's due to the second critical issue facing our field, and that's the limited number of donor organs compared to the vast need for kidney allografts. At any one time, there's over 100,000 patients typically on the national kidney transplant wait list, and yet we only perform somewhere between 15 and 20,000 kidney transplants a year, highlighting the need to expand the donor supply. And one method of increasing this access to transplantation is increasing utilization of marginal kidneys that would typically be discarded. So in this discussion of marginal kidneys, we have to consider the Kidney Donor Profile Index, or KDPI. So the KDPI looks at a variety of clinical factors, such as the age of the donor, the BMI, the history of hypertension or diabetes or hepatitis C, the cause of death, the terminal creatinine, and whether it was a donor after circulatory death. And all those factors are compiled into a profile index that runs from 0 to 100%, with a 0% being the most ideal kidney possible, and 100% KDPI kidney being one that is much more marginal with a much diminished expected graft half-life. And we commonly make a separate category of high KDPI kidneys, which we define as any KDPI kidney above 85%. And as this chart shows, those kidneys would be expected to have at least a 50% decrease in the estimated graft half-life. So the number of years that the kidney is functional and it keeps the recipient off of dialysis compared to a standard criteria kidney. So who do we use these high KDPI kidneys in? Well, certainly a typical recipient of this high KDPI kidney may be an older patient with a short wait time, because that patient is much more likely to die on the wait list than to receive a standard criteria kidney. And additionally, these older patients, even if the kidney only keeps them off dialysis for 7 to 10 years, that may be the length of their expected lifespan. So they may have, again, that one kidney for life, which is our goal for all of our patients. We wouldn't want to utilize these kidneys in very young patients, as they likely will need a subsequent kidney transplant after use of these high KDPI kidneys. But in an older patient with a short wait time, or in another patient with a short wait time that is expected to have to wait a long time for a kidney transplant, these more marginal high KDPI kidneys may be a very good clinical option. So when we use these high KDPI kidneys, because they're often transplanted into older recipients, many centers utilizing these marginal kidneys try to avoid over immunosuppression of these recipients of high KDPI kidneys. And that's for two reasons. Because they're usually placed in older transplant recipients, they have a higher risk of over-immunosuppression and subsequent infectious complications, which may shorten patient life and allograft survival. The other reason to use reduced intensity immunosuppression for these marginal kidneys is because we know that CNI intensive maintenance immunosuppression regimens increase the risk of nephrotoxicity, which may be especially catastrophic in these marginal kidneys that already don't have ideal allograft function. So when using these high KDPI kidneys, we often try to use less intensive CNI sparing or CNI minimizing immunosuppression to mitigate the nephrotoxicity associated with that maintenance immunosuppression. So what are some strategies we can utilize to minimize CNI exposure in kidney transplant recipients? Well, certainly one possibility that's been explored by several groups is the use of mTOR inhibitors, such as sirolimus or everolimus, to substitute for CNIs, such as tacrolimus-based maintenance immunosuppression regimens. There have been several studies of the use of these mTOR inhibitors in kidney transplant recipients. One of these seminal studies was the Orion study, which randomized patients to either conventional immunosuppression with tacrolimus and MMF, that's that group 3, a separate group that was sirolimus and MMF, and then another group that was sirolimus with minimal tacrolimus that was then tapered off. And what we found is that the group 2, the completely CNI sparing group, this group was actually terminated early due to an elevated incidence of biopsy-confirmed acute rejection. And the rates of graft loss were numerically higher in both of the sirolimus-based limbs of the study. And there was also more adverse effects due to the known toxicity of these mTOR inhibitors that led to discontinuation of sirolimus in groups 1 and 2. So not a very positive study for the use of mTOR inhibitors as a strategy to minimize CNI use. ZEUS was another important clinical trial. This one used everolimus-based immunosuppression versus cyclosporin-based regimens in kidney transplant recipients. And it was comparing patients that were receiving either cyclosporin MMF and corticosteroid versus everolimus MMF and corticosteroids. Post-randomization, they did certainly find that the eGFR was improved on the everolimus-based limb of the study, but biopsy-confirmed acute rejection was significantly higher in the everolimus group. And there was also a significant rates of adverse effects with the everolimus group. So you can see here that the cumulative probability of biopsy-confirmed acute rejection was definitely higher in this blue line, which is the everolimus receiving arm of the study. So 2 significant studies of mTOR inhibitors as a means to minimize or eliminate CNI in maintenance immunosuppression for kidney transplant recipients, and both of them not providing much support. And this is one significant reason why mTOR inhibitors are fairly rarely used for maintenance immunosuppression and really reserved for patients who develop significant nephrotoxicity with CNIs. One novel immunosuppression strategy to minimize the use of CNIs in transplant recipients is the use of costimulatory blockade agents, which has really emerged as a very promising means of sparing CNIs for our kidney transplant recipients. These drugs especially include belatacept, which is the only currently FDA-approved costimulatory blockade agent for use in renal transplant recipients. And this, again, targets that signal 2 of T-cell activation, which is required for the activation of naive T cells. And so the belatacept is based on an older drug, CTLA-4 Ig, or abatacept, and it tightly binds to CD28, much higher than B7, the activating ligand of CD28 binds to CD28, and so it therefore serves as a competitive inhibitor of CD28 activation and blocks the costimulatory signals sent through CD28 ligation. The belatacept for kidney transplantation was best investigated in the seminal BENEFIT trials and the BENEFIT-EXT trials, which is actually the largest trial of immunosuppression in the history of kidney transplantation. This study looked at a regimen of basiliximab induction with MMF and prednisone, and then compared it to either low or moderate intensive belatacept therapy or a control arm that received cyclosporin therapy. And there were several really important findings of this BENEFIT trial. One was that the acute rejection rates are significantly higher in the short term with the belatacept containing regimens. And you can see here, looking at compared to cyclosporin, there's really a significant rate, especially in the BENEFIT trial, of acute rejection at 1 year. And then when we first utilized this drug at Emory, we were finding rejection rates in our less screened transplant recipient populations, or more real-world population. We were finding ACR rates approaching 50% initially, which would obviously be prohibitive. This is counterbalanced by the real benefits of the belatacept regimens and that's improved graft function in the long term. So you can see here, and this is the 7-year follow-up data, there's significantly improved GFR in the transplant recipients receiving belatacept-containing immunosuppression versus those who received the conventional cyclosporin-containing immunosuppression. And this was actually validated as well in the long-term follow-ups, that there was improved mortality in the kidney transplant recipients that received belatacept compared to those who received cyclosporin. This is another study showing that both patient and graft survival were significantly higher with belatacept-containing regimens compared to those receiving conventional immunosuppression with cyclosporin. The success of the BENEFIT trials led many groups to try to explore the utility of belatacept in immunosuppression regimens that spared not just CNI, but also steroid. But compared to the BENEFIT trials, however, many of these studies of de novo steroid and CNI-sparing regimens have been much less promising. So the CTOT-10 study was one of the first of these studies, and this looked at depletional alemtuzumab induction in a CNI-free steroid-sparing regimen using belatacept. But this trial was stopped early due to higher rates of both acute rejection as well as vascular thrombosis of the grafts. The CTOT-16 study tried using depletional thymoglobulin with belatacept in a CNI-sparing rapid steroid taper group, and this study was also stopped earlier due to higher rejection rates. And finally, the BEST study, which was one of the larger studies, looked at groups of both alemtuzumab as well as thymoglobulin induction. But this again found that while the eGFR was significantly higher in belatacept-treated groups, there were higher rates of biopsy-confirmed acute rejection in these steroid-sparing, CNI-sparing, belatacept-based regimens compared to conventional immunosuppression with tacrolimus and steroids. So these studies all caution against adopting de novo corticosteroid and CNI-sparing belatacept-based regimens for maintenance immunosuppression without a better means of identifying patients' risk of rejection or identifying biomarkers to predict rejection. There have been some consensus recommendations published that affirm the use of belatacept in kidney transplant recipients. This is one from 2022 in pharmacotherapy that was an expert consensus panel of multidisciplinary experts. And it found that in EBV seropositive patients, and I'll get into the reasons for that, belatacept use may lead to both improved metabolic outcomes as well as improved kidney function in kidney transplant recipients. And that the increased risk of early rejection with belatacept-based regimens is counterbalanced by decreased long-term death and allograft loss in these kidney transplant recipients. The use of belatacept in liver transplant patients has been explored, but was associated with increased risk of early graft loss. So there's actually a black box warning against the use of belatacept de novo in liver transplant recipients. Although some centers, including our own, have successfully used belatacept-based immunosuppression in subsequent kidney after liver transplant recipients. And we've converted those patients who are long-term liver transplant recipients who require a kidney transplant after the liver transplant. We've converted them to belatacept-based immunosuppression with good results and good graft function in both the liver and the kidney. The use of belatacept has also been explored in other allografts, such as heart and lung, but the results have not been as encouraging. So for right now, belatacept only has an FDA indication for kidney transplant recipients. So which transplant recipient should not receive de novo belatacept? Well, there's a few categories to highlight. One of the most important is the EBV naive recipients, or those for whom serostatus is unknown. And the reason for this is that there was an increased signal of post-transplant lymphoproliferative disease, or PTLD, in the BENEFIT trials that was specific to EBV-naive recipients. So there's actually a black box warning for belatacept against the use of belatacept in any transplant recipient who's EBV-naive by serology. Other groups who likely shouldn't receive belatacept, including any of those with a history of hematologic malignancy due to that increased signal for PTLD. And a more recent one that we've started using at Emory is any CMV high-risk patient. And that's because we found that in a CMV high-risk patient, namely one where it's a CMV-naive recipient receiving a CMV-positive donor kidney, the use of belatacept is associated with a higher rate of resistant and refractory CMV in those patients. So we are not utilizing belatacept for CMV high-risk patients. A more controversial one is the HIV-positive recipient population. Initially, due to those higher rates of rejection in the belatacept studies, many centers excluded HIV-positive recipients from belatacept-based immunosuppression. But there have been several encouraging studies since then, and many centers, including our own, now will use belatacept even in HIV-positive recipients. The higher rates of acute rejection certainly have given pause to many centers to broaden the utilization of belatacept. And certainly when we first began clinically using belatacept off study, we did encounter these high rates of early rejection in our transplant recipients. And that really drove us to try to develop better regimens to address this. As we've shown through the CTOT-10, CTOT-16, and the BEST study, depletional induction, which was hoped to be a way to to achieve lower rates of acute rejection in belatacept-based immunosuppression regimens, really haven't yielded significant benefits. And many of those studies utilizing depletional induction with thymoglobulin or alemtuzumab and belatacept were either aborted early or still found increased rates of a biopsy-confirmed rejection. We actually approached at Emory a different strategy to address this issue, and that was the use of a transient course of CNI early in the post-transplant course when the patient was most vulnerable to acute rejection, with subsequent weaning of that CNI. So our current regimen at Emory is we start these patients on quadruple therapy with both tacrolimus, belatacept, MMF, and prednisone as their maintenance immunosuppression. And then starting at 9 months post-transplant, we start weaning the tacrolimus with a goal to wean it off completely by 11 months post-transplant. And at that point, the patient's maintained just on belatacept, MMF, and prednisone. What we found utilizing this regimen is that our rates of early acute rejection are actually identical to our historic controls using TAC, MMF, prednisone, and yet we still glean all the long-term benefits with improved eGFR that we see with belatacept therapy at that 1 year and beyond time point. So it's a way of minimizing the early graft rejection while still accruing those long-term benefits of belatacept therapy. Now, despite the fact that belatacept was clinically approved in 2011, it really has not been widely adopted yet in transplant centers. Less than 5% of kidney transplant recipients receive belatacept using for their de novo immunosuppression regimen. Emory is definitely an outlier. About 70% of our patients actually receive belatacept at de novo, and that's pretty much every patient we have who's not EBV naive or has one of the other exclusion criteria, such as being CMV high risk or a history of hematologic malignancy. So we've definitely shown that you can aggressively utilize belatacept with very good results. There have been several barriers to the increased utilization of belatacept clinically. Certainly one of the most important ones we've discussed, which is the increased risk of acute cellular rejection that was identified in the BENEFIT trial. And hopefully we've addressed several strategies that you can utilize to address this concern. And that includes using a low-dose TAC taper in order to minimize the risk of rejection in the early post-transplant period, and then ultimately wean that CNI off. And then use of depletional induction or potentially use of other immunosuppression induction agents in the pipeline can also help mitigate this early risk of ACR that's seen with belatacept. Another strategy is to start the patient on TAC-based immunosuppression and then convert them to belatacept at a later point when they're less likely to reject. Beyond the increased risk of ACR, though, another formidable barrier to the greater utilization of belatacept has just been the logistical barriers, as many centers aren't able to offer monthly infusions of belatacept for their transplant patients. We've actually built out an entire infusion center in our transplant clinic to facilitate the monthly administration of belatacept in our transplant recipients, and that's been inordinately helpful for offering belatacept therapy as the gold standard for our kidney transplant recipients. But there have been several other strategies and possible routes to overcome these logistical barriers. One is the use of bimonthly administration, as we know that the half-life of belatacept is longer than 1 month. There have been some studies performed at our center in low immunologic risk patients showing that that conversion at a year post-transplant to a bimonthly regimen it still maintains very good allograft functions and definitely decreases the logistical burden of monthly infusion. Another possible route to consider in the future is subcutaneous formulations of belatacept. The precursor drug of belatacept, the abatacept, which has only 2 point mutations compared to belatacept, is clinically utilized for rheumatoid arthritis, and they actually do offer subcutaneous forms of abatacept. So use of subcutaneous administrations of either belatacept or abatacept in low immunologic risk patients may be a way of circumventing the logistical barriers of monthly infusion. And then the final barrier to wider clinical adoption of belatacept are the somewhat limited indications for its use. But there have been a number of studies that have offered the potential opportunity to greater expansion of these clinical indications for belatacept use. And that includes the use of belatacept in pediatric renal transplant, in extrarenal or multi-organ transplant. And again, we've had some very successful results with kidney after liver transplant and even kidney heart transplant. Use of belatacept in treatment of donor-specific antibody or acute or antibody-mediated rejection. And finally, its use in desensitization regimens. All of these are currently off-label, I should say, for belatacept. This last potential off-label indication highlights a final category of patients that are minimally served by existing kidney transplant allocation, and that's the highly sensitized kidney transplant candidates. So those candidates who may have either had a prior transplant or through pregnancy or through prior blood transfusion, if they have a lot of anti-HLA antibodies, they may be able to receive very, very few kidney allografts. So those patients with a CPRA in the 99.5 or even 100% level are going to qualify for very, very few kidney transplants, and they may wait an extremely prolonged period until they're offered a matching kidney transplant. And so our field needs to urgently develop more effective methods to address this inequity and better serve these highly sensitized candidates. And one strategy to do that is through desensitization. And again, belatacept here may be a very formidable weapon to use to desensitize these patients and make them better candidates for a wider variety of kidney allografts. And there have been several studies of desensitization using belatacept-containing regimens. These are small pilot studies at this point, but offer some promise for a more expanded clinical trial. So one strategy was in the ADAPT trial, and this was the coupling belatacept with carfilzomib, which is a selective proteasome inhibitor. And this causes plasma cell depletion. And the combination of plasma cell depletion with belatacept, which is extremely efficacious in reducing de novo donor-specific antibody formation, has been utilized to desensitize potential candidates for transplant and hopefully allow them access to transplantation. The ATTAIN study, which was the use of belatacept with daratumumab, which is an anti-CD38 agent that also targets plasma cells, also showed some promise to expand the ability of highly sensitized patients with very high panel reactive antibodies and desensitize them and allow them to achieve HLA-compatible transplantation. Finally, I want to talk a little bit about what's on the horizon, and this includes some novel immunosuppressants currently in development and in testing for kidney transplant recipients. And many of these are third-generation co-stimulatory blockade agents that can better block CD28 or block CD28 or one of the other co-stimulatory blockade pathways, such as CD40 ligand. So FR104 is an antagonistic pegylated anti-CD28 Fab antibody that selectively blocks CD28 B7 interaction. And the benefit of this compared to belatacept is that it doesn't block CTLA-4, which is an inhibitory receptor that inhibits T cells. So belatacept actually disrupts CTLA-4 signaling, and whereas FR104 does not. And so there have been some promising phase 1 and phase 2 trials that are currently ongoing of the use of this agent in kidney transplant recipients. Tegoprubart is an anti-CD40 ligand antibody that again targets that secondary costimulatory pathway, the CD40 ligand. And there's currently phase 1b, 2, and long-term safety and efficacy trials ongoing of this agent. And dazodalibep is an Fc-silent CD40 ligand protein antagonist that's being studied in combination with belatacept as a dual costimulatory blockade strategy. Finally, the development of more selective induction therapies may also enhance belatacept-based maintenance immunosuppression regimens. And there's currently the ASCEND trial looking at ciplizumab, which is an anti-CD2 depleting monoclonal antibody as an induction agent in CNI-free immunosuppression with belatacept. So as the final portion of this talk, I'd like to move on to a case study. So this is Alexandra, who's a 69-year-old woman with end-stage renal disease and lupus nephritis. And she's both older and has minimal wait time. She's been on dialysis for less than 1 year. So a patient such as this is an ideal candidate to receive a high KDBI kidney because depending on her blood type, if she's an O or a B, she may easily wait 8+ years on dialysis, and she may very well have a waitless death before she's even offered a deceased donor kidney transplant, where she may have a much reduced wait time if she's willing to accept a high KDBI kidney. So how do we discuss kidney transplant goals and expectations in patients like her who are older but have minimal time on the wait list? I think it's important here to have a very data-driven discussion based on her blood type about what her expected weight for a standard criteria kidney is and contrast that with her expected death rate waiting on dialysis given her age. And I often talk to patients that you can have several different cars. You can drive a Ferrari or you could drive a Toyota, and both will get you to where you want to go, which is to be off dialysis. And you don't necessarily need that kidney from the 20-year-old gunshot wound to the head patient that you have to wait 8 years from, and frankly will probably die before you ever see. You want a kidney that's going to get you off dialysis now. And if that kidney keeps you off dialysis for 7 to 10 years, that likely is going to keep you off dialysis for the rest of your life. You likely don't need a kidney that's going to last you 30 years because you're not going to last 30 years. And I think patients appreciate a very frank discussion of what the goals of kidney transplant are. And when you have this frank discussion, the overwhelming majority of these older patients with minimal wait time are willing to accept a more marginal kidney, such as these high KDPI kidneys, or kidneys from patients that are hepatitis C positive or hepatitis B positive. So the focus is really just getting them a kidney that's going to achieve the job of getting them off dialysis, and hopefully off dialysis for the rest of their life. So Alexandra actually did undergo kidney transplant with a high KDPI kidney that she was able to attain with a fairly minimal wait time. So she got transplanted in short order after a few months, and now 2 years have passed. She's now 71 years old. She received a de novo maintenance immunosuppression that was a very conventional regimen with tacrolimus, MMF, and prednisone. But then her transplant nephrologist noticed that she was having a rising serum creatinine. They performed a biopsy, which showed not rejection, but instead evidence of CNI toxicity. So what could be a good option for Alexandra to really optimize the survival of her marginal kidney allograft and hopefully have it last the rest of her life? Well, given the timing of this biopsy finding and showings of CNI toxicity and her desire to reduce nephrotoxicity, she was actually switched to belatacept since she was EBV experienced on her serologies, and then had subsequent stabilization of her serum creatinine with no further reduction. So when we're talking about belatacept to patients, we counsel them that this is a monthly infusion that can be given just in about 30 minutes in the healthcare setting. It's a fairly well-tolerated drug with very minimal side effects, actually. And we actually emphasize that to patients. This is not going to typically give you all the metabolic side effects that tacrolimus can. It's not going to cause a lot of the GI side effects that we see with antimetabolites such as MMF. It's really the primary side effects are that of what you find with any maintenance immunosuppression agent, and that's an increased risk of infection. So that's the primary one that we warn them of. We do tell them about post-transplant lymphoproliferative disease, and that this was observed at a higher rate, especially in the EBV negative patient population. So as long as the recipient is EBV experienced on serology, we feel that there's a very good safety margin with this drug. And like any maintenance immunosuppression, we want to avoid live vaccines in patients receiving belatacept therapy. While the field of transplantation has had some dramatic advances over the last few decades, there remain some very significant existential barriers to the effective care of patients with end-stage renal disease. And that includes the sort of non-improved long-term outcomes and continued long-term graft failures that we see in patients receiving traditional immunosuppression, as well as the problems with access to transplantation in some patients, as there's not nearly enough allografts and donor organs available to serve the burgeoning populations of end-stage renal disease in our country. So to better serve these patients, we need to better utilize marginal kidney transplants. And one important linchpin of greater utilization of these marginal kidneys is, for many of these patients, is to adopt CNI sparing or minimizing maintenance immunosuppression regimens that are not going to have the long-term nephrotoxicity we see with cyclosporin or tacrolimus-based immunosuppression regimens. And this can include several options, including the use of mTOR inhibitors, but probably the most promising strategy to minimize or spare CNI in kidney transplant recipients is the use of co-stimulatory blockade agents such as belatacept. And there's a lot of promise in the field to utilize belatacept to minimize CNI and achieve superior long-term patient survival and patient allograft survival in kidney transplant recipients.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb. To access all materials for this activity, visit peerview.com/SVZ860.